Hello, and welcome to Human Rights Here Now, a program that serves Santa Cruz County residents and talks about issues affecting human rights in our county. Today we will be talking about the End-of-Life Option Act, which is a legislation that was recently passed that gives people at the end of their lives, people with terminal illness, the right to have more control over the last moments of their life. And my name is Virginia Wright. I work for Compassion and Choices, which is a nonprofit that helps, again, empower people at their end of their life. Here with me today in the studio are two people who've done a lot of work talking about the Act and sharing with people about how the Act you can actually use the Act. And so you'll find out a lot of really valuable practical information for you and your loved ones if you should want to use the End-of-Life Option Act. Here to my left is Alina Hammer, and she is a patient advocate and a volunteer with Compassion and Choices. And then Dr. Susan Hughmanick, and she is a doctor, physician, and also an advocate and both community organizers, and have done a lot of this kind of very powerful work to help people in their last moments. Compassion and Choices is a nonprofit that works. We helped bring the Act into existence, and then we work to help educate people to use the Act in states where the Act has passed. So I first just want to start out, before we get into the details of the Act, to just ask Susan and Alina why they came to this work, just a little bit about their background, so we can sort of understand why you're doing this work for people.
So as Virginia said, my name is Susan Hughmanick. I'm an OBGYN, and I've practiced in Santa Cruz County for over 25 years. People might wonder what an obstetrician is doing, talking about the end of life after spending my career ushering new life into the world. And it came through personal, professional experiences and revelation that began at bedsides of my mother and my aunt. My mother died at age 93 and a half, and she was diagnosed with lung cancer when she was 88. She wanted everything done, everything, and she was not ready to die. She'd even said she wanted to die in a hospital, but in the end she died peacefully at home with her 6 children and 6 grandchildren surrounding her, and we sang her as she left, as she transitioned to the next realm. My beloved aunt, who took care of me when I was a skunk of an adolescent, had a different end, and she died an anguished death in an ICU in Reno, Nevada. When I arrived to see her, she was plugged into a CPAP machine, being quite brutally ventilated. So people who think CPAP is benign, it is not. She had tubes coming out of every orifice, including 2 that had been recently surgically created. The family had had no communication with the attending physician, even though they had tried to contact him. So the hospitalist was not coming around to tell them her progress. When the physician niece, myself, arrived, he finally came in and said, well, in fact, she'd been neurologically dead for some time. And in that moment, I wondered, why was she still plugged in? Why was she still experiencing this horrible, brutal medical intervention with lights and noise and confusion when she was already departed? So at that moment, I realized something was amiss in end-of-life care in modern medicine. And a number of books I've read and lectures I've attended have reinforced that concern. So I decided to work with Compassion and Choices because I think we need social change in medicine, and this is a very important topic to me.
Yes, thank you for sharing it. You hear these stories quite a lot from people, and it's wonderful that you brought your caring to this topic. Thank you.
Thank you.
And my name is Alina. I'm actually a retired bus driver here from Santa Cruz Metro. Some of you may know me from there. You may even have ridden my bus. I've been a political activist for most of my adult life, and medical aid in dying came on my radar when AIDS came to our community in the early 80s. People were suffering and dying horrible, horrible deaths, and they were asking for help. And the only thing back then was the Hemlock Society with Derek Humphrey. It was even before Jack Kevorkian came on the scene. So there was no way to help people. It was really difficult. It's been a 35-year struggle to get this law passed, but it is now law in California. And I want to say that I am grateful to Compassion and Choices for bringing this issue to California. I'm grateful to Brittany Maynard and her family for lending her story and her voice to this topic, which helped move through the legislature much quicker. I'm grateful to Bill Monning and all the legislators that supported this bill, and to the hundreds of volunteers that made this happen. And I want everybody to know that every bit of work that I do, every trip up to Sacramento to attend a legislative hearing, every presentation, including this one, I do in honor and memory of all the folks that died and such horrible suffering during the AIDS epidemic. That's what motivates me.
Thank you. Thank you for bringing your passion to this important cause. So, why don't we start with Susan? Can you give us a little background on the bill and when it went into effect and how it got started?
Right. California is the 5th state to legalize medical aid in dying. It followed Oregon, Washington, Montana, and Vermont. And just 3 days ago, Colorado, by voter initiative, did overwhelmingly pass medical aid in dying in that state. Additionally, there are 30 legislatures where medical aid in dying is being seriously considered. So it's on the agenda across the nation, and it's going to probably go state by state. It's also legal in Canada and in Colombia, South America. So what I wanted to say is that when it was signed into law on October 5th, 2015 by Governor Jerry Brown, he remember, was an ex-Jesuit seminarian, and when he signed the law, he wrote, and I want to quote him, "I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." Can't read it. So I think the last sentence is really important. The last sentence does talk to the social justice issue about choice. And Compassion and Choices is all about letting people know that there are choices. Also, there's growing support among the Catholics. 55% of Catholics around the country now support medical aid in dying, and 70% of Americans in a recent Gallup poll supported medical aid in dying. So we do have the terrain shifting in favor of this. One thing that very much influenced me was the writing of Atule Gawande, and Atule Gawande wrote a book called Being Mortal.
Oh, yeah.
And in it, he reminded us that 200 years ago, people used to die, live fairly healthy lives, and then would die abruptly, catastrophically,
Right.
from cholera, being gored by a bull, losing a shootout in a duel, but people died quickly. Now in modern medicine, we live longer and healthier than we ever have in the past,
Right.
but the dying process has become quite prolonged. So instead of dying abruptly, now we have a roller coaster, up and down roller coaster toward our final moments,
Right.
with interventions, a little bit of improvement, further decline until the very end. So what he has written in his book is that scientific advances have turned death and dying and aging in America into medical experiences, and the medical world has proved alarmingly unprepared for it.
Right.
We do know from the Journal of Aging in America that most people want to die at home, surrounded by their loved ones, with their pain and their symptoms managed, their spiritual needs met, and not to be a devastating burden on their families. Because we haven't done our homework, we find that only 30% of Americans have completed their advance directives, And when they have, only a quarter of those doctors know about it. So what happens in America is that 70% of people now die in a hospital or a healthcare facility instead of dying at home as they've expressed their preference to be. And we also learned from the Institute of Medicine study published in 2014 that doctors are not good at talking to their patients about dying and the end-of-life experience.
Right.
We also know that the financial interests in medicine align with doing more procedures, more interventions, more chemotherapy, not in counseling patients and letting them to choose their end. That's the problem we're facing now.
Right. Well, and it is changing, however, which is very good. I mean, the palliative care movement, the hospice movement, and now the end-of-life movement is real. There are steps being done. There's lots of books, if you've mentioned some. There's other books that are out there that are very powerful, and there's people like you that are doing this work. You said there was hundreds of people, volunteers, and I just was looking at some of the work, and there was actually 1,500 volunteers that helped in California alone, in one state, who worked on this issue because people feel so powerful because they've had.
Very moving.
It's very moving. They've had an experience, their loved ones have had this kind of experience where you get on the train and then the stopping dying at all costs and you forget about the quality of life. Mm-hmm. And so it's an exciting time in a way to be a part of a movement that is moving forward right now. Mm-hmm. And reducing fear and getting people to talk about death and dying and then changing the laws. So thank you. And one of you, I don't know, Susan, do you also want to talk about how the bill, became law on June 9th of this year? It was signed in October, but it became law on June 9th for people to use it.
Right.
It's me.
Mm-hmm.
So
I'll talk about it.
You want to talk a little bit about the actual, what happened when and what are the qualifications, a little bit more about the bill itself. What are the qualifications for people?
So it did get enacted on June 9th of this year, even though it was passed into law on October 5th. And now Alina's going to discuss how you qualify.
Well, first I'll give a definition of what medical aid in dying is. It's a practice that allows a patient to request medication from their physician that they can take when they decide that they can no longer tolerate their pain and suffering, and then they can end their life peacefully. Sometimes they call it death with dignity. I think they use that terminology in Oregon a lot. But so let's talk about what are the qualifications. You got to be an adult of 18 years of age or older. You have to have a terminal diagnosis with a 6-month prognosis or less to live. You have to be mentally capable of making your own health care decisions, and you have to be physically capable to self-administer and inject the medication. If a patient is on a feeding tube, for example, they would be allowed to inject the medication into their tube, but they have to be able to do that. Nobody else can do that for them. Somebody else can mix sometimes depending on what medication you use, you'll take medication pills, so you open it up and you put the powder in the water, and somebody else can do that for you. But you have to be able to ingest it yourself.
And so you've gone around to different communities and retirement homes and community centers, and you've talked about this to people, and people ask you these questions, and is there a question that you get most often?
Yeah, no, I don't know. Do you have an answer to that?
Well, people want to be able to have this option even if they have Alzheimer's or a stroke.
I know.
And we have had to tell them repeatedly that you have to be mentally competent up to the moment that you ingest the medication.
Right,
so people are wanting the bill to do more than it currently does. We tell them we're progressing in baby steps.
Right, right.
You also have to be a California resident.
Right.
And so the way that you would show that is either by a driver's license or maybe a property lease or a California ID or let's see, I think maybe a PG&E bill, voter registration, or a state tax return. And actually, before I give it back to Virginia, I want people to know that toward the end of this show, we're going to be sharing some contact information with you. And it's going to be a couple of websites and some 800 numbers and hotlines. So get your papers and pens ready, or your iPads or your phones, whatever you use to make notes, so you'll be ready to get the information when we put it up there for you.
Yeah,
Back to you, Virginia.
Thank you for that. And Susan, so how do you actually access the law? Let's say you're interested. How does that work? How does one access it?
Right. So this is the nuts and bolts of the law. And I want to go over it in kind of exquisite detail, maybe excruciating detail, because I think that patients and families need to know. The law is full of safeguards, and because of that, there are many steps. The first thing is that a patient must make 2 oral requests directly to their attending physician, their primary care doctor, or the main doctor in their life who cares for them.
So it's their primary. So a lot of people have their primary care, then they have specialists they're working with. They have to. It has to be the primary doctor.
The doctor who's doing most of their care and knows them the best is probably the right person.
Okay.
But it's not etched in the law.
Okay.
Then there's a 2-week window, a 15-day window between the first oral request and the second oral request. That time is etched in stone. It can't be compressed. After they make those 2 oral requests, they must also see a consultant physician who is independent of their primary care doctor, not working in the same office, not a buddy of the doctor, but somebody independent. And there are a number of steps that they have to go through.
Can it be one of the specialists they're working with?
It certainly
It
could be.
if they
one
were
of the
maybe in
specialists.
different offices.
In Santa Cruz County, hospice has stepped up to say that they will be the second opinion for our patients. So we have that already laid out as policy in hospice.
So in Santa Cruz, the hospice of Santa Cruz.
Hospice of Santa Cruz.
That's great.
So the other thing is that then the patient has to have a written request, give a written request to the primary care doctor after the 2 consultations have been done. And if the doctors both agree, this must be witnessed by 2 people, only one of whom can be related to the patient by marriage, blood, adoption, or property interests, and only one of whom can work at the healthcare facility where the patient is receiving treatment. The doctors cannot witness this. So that's...
But it doesn't have to be legally witnessed, but just with somebody's signature. It doesn't have to
well,
be...
it's on the forms that get submitted to the state to verify compliance. Additionally, we haven't spoken about this before. If there's a language barrier and a translator is needed, then that translator has to be a health certified translator. And they also have to sign the form, the attestation forms that are submitted to the state.
Right.
The
So
state watches this very closely.
Very, very carefully, and there's a lot of safeguards.
So I wanted to speak further to that. The attending physician must meet directly and alone with the patient to be sure there's no coercion or outside influence. The other thing is they must determine the residency, and there's not a window of time that's required like in Oregon, but it is the residency requirements that Alina mentioned.
To be a resident of the state of California.
Right. And then both attending and consulting physicians must agree on the diagnosis, the prognosis, the patient's mental capacity, which means they have the ability to make informed consent about their health care. They understand the risks, the benefits, the consequences of using medical aid in dying. So those are all things that have to be agreed upon, and there are checklists that the physicians must go through.
So
The patient also they have to be sure the patient's acting voluntarily, and they also have to say that the patient understands that they have to keep the drug in a safe place, a safe, secure place. It is a lethal medication, that someone must be present when they take it. They can't take it in a public place. Even if you love the Big Sur coast, you can't go down there and pull out on the side of the road and take the medication. Must be not a public place. And also that they can take the medication, get the prescription, get the drug, but withdraw their request at any time. And there are 4 places in the paperwork where they're offered the right to rescind their request.
You've mentioned, this is a lot of information for anyone. You mentioned the paperwork. Where do they get that paperwork? Where do they find that?
The paperwork. Oh, it's great. There are 2 places. I have it from the California Hospital Association, did a nice summary of the End of Life Option Act, and in the second part of that summary, all the paperwork is there. They can also download the paperwork from the California State Department of Public Health, easily online.
The California State Department of Public Health has that, so that you could Google that and you could find that document and you could sort of go through those things that you just mentioned, all the requirements and what you have to do and the steps you have to take.
There's another thing that I needed to say. For the attending physician to be in compliance with the law, they must counsel a patient about the importance of participating in palliative care or hospice care. And in Oregon, 92% of the patients who pursued death with dignity were in hospice care. We talked about the safe maintenance of the drug. They must counsel about the importance of notifying next of kin that they made this request. And again, the right to rescind or withdraw their request at any time. And one other thing is there are some reporting forms that the physician has to fill out before and after the patient dies.
And the doctor
to be
would have
in compliance with the law.
And the doctor would have those forms.
They're all part of the download.
The downloadable
Yes.
form. Great. It's a lot, but there was a reason. We wanted to. It's a new law, and it needs to have a lot of safeguards. It's one of the reasons I think that it was passed, is because so many safeguards were in place. But as part of the law, there's the doctor has to share with you all options. So can you share a little bit about what those options are?
That's a good question. So what are the other end-of-life options? There have been many, many end-of-life options that already been in place. For example, a patient could accept all curative treatment that was recommended to them, or they could choose to do some of the treatments and reject some of the other treatments, or they could reject all treatments. They might want to be at home instead of in the hospital and have hospice come in and get comfort care only. They would use palliative care for that, which is the use of medications to provide comfort care while a person is suffering. But we know that 25% of people on palliative care do not have their pain adequately controlled by medication. There's voluntary stopping of eating and drinking, which is a complete cessation of all food and water. It's something that you can't do alone. It depends on how debilitated the patient is, how long it will take to die. It could take from 2 days to 3 days to 2 weeks, maybe even longer. But it was something that we saw actually during the AIDS epidemic because it was something legal that people could do. But it's not easy to do, and you can't do it alone. There is also palliative sedation, which Dr. Susan is going to talk about in just a minute. This is a process where your physician will decide when she feels that she can no longer manage your pain adequately with medication. She can induce sedation, where you will stay until you die. But I want to make the point that this is a doctor-driven system, where it's the doctor decides when the pain is intolerable. But now we have medical aid in dying, which is a patient-driven system, where it's the patient that decides. Once you qualify for the law, it's the patient that's going to decide when to take the medication and not. And that's what we're looking for, is a patient-driven system.
So I wanted to just comment about a couple of cases. With the voluntary stopping eating and drinking, the NPR radio host Diane Rehm wrote about this in her book, On My Own. And her husband had advancing Parkinsonism. He first lost the ability to use his legs, to stand, and when he finally had this ascending paralysis, he lost the ability to use his hands. And this is a man who'd been a diplomat, he'd been in the State Department, he'd been in 2 or 3 White Houses. He was a very high-functioning individual, and when he could no longer use his hands, he asked his doctor in Maryland, please help me end my life.
Right.
And the doctor said, no, there's nothing I can do, it's not legal. And at that moment, he was in hospice. At that moment, when he was denied any help, he just stopped eating and drinking. And Diane Rehm was by his side for 2 weeks while he dehydrated and starved to death. And it was a very, very brutal experience.
Right.
And she raged against it in her book, and in fact, she will be an advocate and a volunteer for Compassion and Choices in the East Coast as this movement spreads to the east.
She has been very, very supportive of Compassion and Choices.
And regarding palliative sedation, one of the very vocal advocates for the legislation in Sacramento, who was herself dying of lung cancer, began to die before the law was enacted. And her suffering was so great, she was put into palliative sedation.
Right.
But the problem with palliative sedation in her case is that she kept waking up. And when she woke up, she was terrified, she couldn't breathe, and it was a terrible, terrible death that she suffered.
Right. Well, so I've been hearing you talk, and we using language that's like medical aid in dying or death with dignity. And why isn't it suicide? Why don't you use the word suicide, or why is it not called suicide?
So let me talk to that. This is very important. You know, we say that language matters, and in this case, it really matters. You may hear people using the expression physician-assisted suicide. We heard it a lot in Sacramento when we were trying to get this law passed from the opposition because it's inflammatory language. But I'm going to try to convince you today to use medical aid in dying or a planned death, and I'm going to explain to you why. If somebody dies by suicide, they're usually not terminal. They often have a mental health diagnosis involved, and they don't want to live, is why they're trying to end their life by suicide. But with medical aid in dying, the person is terminal. They'd have to be terminal to qualify. They have to be mentally capable to qualify, and they want to live. They've done everything that's been available to them that they were willing to do, and it's because they're out of options that now they're asking for help in dying. So it's a huge difference between death with medication and death by suicide. Usually a person that ends their life by suicide is most oftentimes alone and often has a violent death. A death by medical treatment is a gentle death, which is actually the point of the whole thing, and families are usually involved. And sometimes now we're even hearing that people are planning their memorial service or their celebration of life, and they're actually attending their own service before they die. So,
and there's also, isn't there legal ramifications too if you're diagnosed with suicide or with using this treatment? There's different implications around.
So I'm going to talk about that in a minute.
Yeah.
Yes,
okay.
you are correct. I'm
Yeah.
going to talk about that in a minute. So we're seeing we're seeing that planned death is now changing actually the face of dying for families. And the other thing is that both ways there's a grieving process, but which is always difficult when you lose a loved one. But in addition to the regular grieving process, the survivors of people that have died by suicide have a guilt that's built into their system. They're like, well, if only, if I had come home early, or if I didn't go to work that day, if I recognized the signs, or I should have done, I could have done. So they're left with a level of guilt that's not involved in the grieving process for other people. So I hope that I've convinced you to change your language on this. And I want to point out that even the law has changed, has recognized this. It speaks specifically, there is language specifically in the law that says medical aid in dying is not considered suicide or assisted suicide. And there's issues being sort of things like insurance policies or annuities. And the language says things like life insurance, wills, contracts, annuities are not and will not be affected by medical aid in dying. The death certificate for the cause of death will show the underlying health disease. That's the only thing that will show. This is important. It protects the privacy of both the patient and the doctor because it's a public document. Before I move on, I want to talk about one other thing that's really important. We call it the early ask. You need to talk to your doctor early, and you need to talk to your doctor often. This process, as spelled out in the law, if everything goes really well, takes between 16 to 17 days if you're in a facility that's participating in the program and there's no glitches. So I don't know how many of you have had contact with medical facilities, but there's a lot of calling, and I'll call you back, I faxed it, I didn't get the fax, I'll fax it again. There's a lot of phone tagging and message sending. So it can take up to 6 to 8 weeks, especially if you're in a facility that's opted out and you need to go and find a facility that will help you. Dr. Susan and I went on a call-in radio show, and somebody called in with this question: what if I'm in a Catholic hospital and I want to use the bill? So unfortunately, the answer is you have to find another hospital and another doctor. If you're healthy and well and home, that's difficult enough to do. Imagine doing it from a hospital bed where you're already facing your own death. So again, ask early and ask often.
And what other, there's other, in addition to being in an opt-out, so part of the law, you want to talk a little bit about what that means, opt-out?
Challenges.
Yeah. Well,
I did
challenges
want
in
to talk
general.
about the challenges that patients face because there are many
Let me,
challenges.
before you go into that, let's just quickly, I want to just define the opt-in, opt-out.
I was going to
yeah.
talk
Are
about
you going
that.
to talk about that too?
Yeah.
Okay. Because I know some people don't know what that,
Oh, right.
what that is.
So the law protects not only the patient, but also the physicians and the healthcare facilities and the hospitals. So what Virginia's asking about is who's participating. And participating or non-participating is an option that allows an individual or an organization to opt out and refuse to participate for reasons of ethics, religion, or conscience.
Right.
So we talk about participating or opting in versus non-participating, prohibiting, or opting out.
Right.
And
what other challenges do people have besides that, opting in and out?
yes,
being
there
in the right
are
system?
challenges, but I wanted to say in terms of prohibiting institutions that a hospital system like we have the Catholic healthcare system, Dominican or Dignity, they can prevent, because they're opt-out, they can prevent their staff from participating in medical aid in dying in the hospital
Right.
or in any space that's owned or operated by the hospital, and even the case of an electronic medical record, which the hospital might own. Any of those physicians, even though most of these activities occur in a physician's office, they are excluded from participating in medical aid in dying by virtue of the Catholic stance against medical aid in dying. So other things that are problems
Right.
are the cost of the drug.
Right, we've heard a lot about that
Now,
lately,
in
unfortunately.
Oregon, there were 20 years of experience with a drug called Seconal, a short-acting barbiturate. And originally, this medication was used as a sleeping pill. One tablet would put you into a happy little sleep.
Right.
The lethal dose is 10 grams or 100 tablets.
100
So, in the past, when it used to cost pennies a tablet, 1 or 2 cents per tablet. Now, because of Big Pharma, Valiant, headquartered in Quebec, Canada, they have taken over the production facility for Seconal, and they've raised the price exorbitantly. So a single dose of medical aid in dying can cost $3,500 to $4,400, a single dose.
Wow. And what about insurance?
Insurance, that's a good question. Thank you. There are insurance companies that have come forward to say that they will cover medical aid in dying. The ones that we know of are Anthem Blue Cross, Blue Shield of California, Kaiser even has a navigator system. So if a patient wants to pursue medical aid in dying, they have a person specifically in their facility who will help them get through and get what they need. So they're
Right.
very, very favorably participating.
Right.
The other companies are HealthNet and Medi-Cal. When Governor Brown signed the
Medi-Cal.
bill, he carved out an option for Medi-Cal to give funding to the medical aid in dying drug. So the cost of the drug and the cost of the counseling is included in those systems. Unfortunately,
Not all systems.
older adults like myself have Medicare, and Medicare does not participate, and neither does the VA system. So those patients who have those two coverages will not get medical aid in dying paid for.
Medicare. Okay. And but you can
Medicare
have
and the VA.
other drugs can be used.
Right. So there are other formulations that are being used in the state of Washington, and we can get that information through Compassionate Choices hotline, pharmacist to pharmacist. So a doctor who wants to participate can call that hotline
Right.
and ask a pharmacist directly what it is, what it costs. And in fact, when we don't have pharmacies here who will release or have these drugs available, they can be sent from Oregon overnight by FedEx, which is a pretty surprising thing, and we thank Compassionate Choices for that.
Yeah, that's been a lot of good work being done for that. Anything else, Alina?
I have a couple things I'd like to
What-
talk about.
What about planning ahead? What about the End of Life Option Act and the Advanced Healthcare Directive?
And before I answer that question, in case you have just tuned in, I want to
Checking in.
reiterate that at the end of the show, we're going to be sharing the information that Dr. Susan was just talking about, the 800 numbers and website, contact information. So get your paper and pens ready, or computers, whatever you use, so you'll be ready when we post the information on the screen. So it's a really good question. People ask a lot, can I plan ahead by putting my request in my Advanced Healthcare Directive for medical aid in dying?
Right.
So the answer is no. The only way that you can qualify for this law is the way that Dr. Susan and I have described to you today. However, let me hasten to emphasize the importance of advanced healthcare directives and PULSEs.
PULSEs.
Stands for Physician's Orders for Life-Sustaining Treatments. These are forms that you will fill out, and you're going to write on there what you do want to happen to you when you can no longer speak for yourself, and what you don't want to happen to you when you no longer can speak for yourself. And you're going to pick an agent that will speak for you when you're no longer able to do that. Just by filling out these forms, it will begin the conversation between you and your family. Well, a conversation that needs to happen of things that you want and don't want when your life is ending, and it will also help your doctor know what you do and what you don't want. So it's kind of a win-win. It's kind of a win-win for everybody. I'll tell my story that when I went to my doctors, and I asked all of them actually, I said, you'll probably be my doctor when I die, will you write the script for me? And so that, I got a different answer from each doctor, but that lets them know what I want, and that lets me know what they will or won't do, and can I count on them. You have to plan ahead, because you might get stuck in a place where you can't speak for yourself. On these forms, you're going to see a lot about family. Dr. Saenz talked about it as well. They're on the Advanced Healthcare Directive forms, and they're also on the End of Life Option forms. It's 2016, and I'm happy to say that the face of families has finally changed. There are people that have been in a relationship for 20, 30 years, and they haven't wanted to marry. Or there were people that wanted to marry, and before marriage equality, they couldn't marry. And we heard endless stories about people in their final hours being separated by the person most important to them because they didn't have their paperwork done. So how do you get the healthcare facility to recognize the person that you identify as your family? It's really easy. You're going to name them as your agent in the Advanced Healthcare Directive and in the pulsed form. And that's the way that you'll get a healthcare facility to recognize the family as you identify it. It's really important.
And when you're thinking about choosing that person, what do you think about? They could be a family member, they could be by law, they could be traditional family, non-traditional, they could be anyone really, right?
It could be anyone.
And so what do you suggest people think about as really important when they're choosing that person to put in that document?
It's got to be somebody that they trust, that will follow through, because they might get some resistance. And now it is somebody, I know the person that I asked, and she kept calling me back and saying, well, I have more questions, and what about this, and what about that? And that is the perfect person that I picked, because she really wanted to be involved, and she wanted to know what I wanted and what I didn't want. And that to me is the most important.
Right, right. That's really good. Good thinking. So even though you can't put this end-of-life option into these documents, they're really important documents to have.
Absolutely.
Absolutely.
We highly encourage, it all works together to make it a smoother transition. So Susan, can you give us a little background about what we've learned from the Oregon experience? Because in Oregon it's been 20 years and they've had a lot of experience, and it started out 20 years ago very differently than how they're working with it now, and they've sort of shifted the way that sort of the focus for medical aid in dying, and that's really of interest to me about getting it into the system, getting it into the medical systems, making sure that all doctors, hospice, palliative care, the medical systems, the insurance, that they're embracing the idea of medical aid in dying and the End-of-Life Option Act. So maybe you could talk a little bit about that as well.
Okay. First of all, the reason that people choose medical aid in dying, we know from the Oregon experience that loss of autonomy is a #1 reason that people pursue this path. Additionally, loss of the ability to enjoy the activities of daily life that make life worth living.
Right.
Being able to get out of bed, being able to eat a chocolate ice cream cone, being able to speak with your family members, less involvement, being bedridden, and being not able to do a thing for yourself. The loss of dignity and the loss of bodily functions that occur with debilitating disease, end-stage disease, not being able to bathe yourself, toilet yourself, feed yourself. All of those are reasons in a kind of a rank order why people in Oregon have chosen this route.
It looks like you're looking at research there. Where does the research happen, or where do you get the information?
Oh my gosh, an abundance of data has been collected in Oregon. There are over 250 articles published in the medical literature that have looked at every aspect of the law and its enactment. They've looked at the effect on doctors, patients, families, hospice workers, healthcare systems. All that data is available from Oregon. So we know this with certainty from very intense scrutiny and investigations.
Right.
I also want to say that an important reason that people have chosen to end their life with medical aid in dying is because loss of ability to control pain. 25%, as Alina mentioned earlier, had inadequate pain control with the best hospice and palliative care. So that is an issue. And about 80% of patients who choose medical aid in dying have cancer, metastatic cancer. As Alina said, they've run out of treatment options or options that they can tolerate. About 8% have advancing neurologic diseases like Lou Gehrig's disease, ALS, advancing Parkinsonism, and other things. And then a smaller percentage have end-stage congestive heart failure, pulmonary fibrosis, and lung disease. So those are the people that are using this law, and those are the reasons primarily that people have taken the medication.
But the numbers of prescriptions given and the people actually taking the medicine, a lot fewer take it than get the prescription, correct?
Right. So what we know is from Oregon is that having the prescription itself is a comfort. It's a sense of control that if the end of life, the death becomes too terrible, too intolerable, that patients don't have to stay and suffer through it.
Right.
It turns out that only about 2/3 of people who get the prescription actually need to use it, and the other third has adequate control with palliative and hospice care. So that's an important issue in this. We also know that initially in Oregon, the doctors and patients didn't know about the law. So only about 5 physicians were prescribing the medication, and very few patients were availing themselves of it.
Right.
Over the 20-year period, that number rose significantly. So now there are probably 120, 130 physicians writing the prescriptions and many, many more patients accessing it.
Right.
And in California, we don't want to see that experience repeated.
Right,
We have
and
a much bigger state, a more
Right.
diverse state, and we're doing the access campaign and reaching out as health care providers and educators so that people will know and have more immediate access to medical aid in dying if they qualify and if they need it.
Right. Just because a law is passed. I was at a political meeting up in San Francisco, and Mark Leno from San Francisco, Assemblyman, said, just because many laws are passed, but fewer are implemented. And I took that to heart when this was passed, because you can have a law that's passed, especially like this, around social justice, around access, around human rights, that it's very good law. But whether or not every Californian has access to that law, that takes a whole other level of work and
Yes, it does.
effort. And you
Certainly does.
working, witness us here today. It takes a lot of work to get the law implemented. So, and Oregon taught a lot of
That is
good
actually
lessons.
what Dr. Susan and I are charged with doing, is educating
Yes.
Santa Cruz County, getting the information out. And it's sometimes an overwhelming feeling, but in the words of Dr. Susan, we will move this mountain.
Yay.
That's what she always
She's
says.
always
Yeah.
quoting me. There are a couple of other things that are interesting about the Oregon experience, and that is that because of the law, end-of-life care has greatly improved in Oregon.
Right.
Doctors are now pursuing education about palliative care, about end-of-life conversations. Only 30% of doctors in Oregon reported having any training at all in end-of-life care and conversations. How do you talk to your patient? How do you bring it up? So that has opened up the discussion, the dialogue between patients, physicians, and families, and vastly improved end-of-life care in Oregon State. The other thing is that it's now being included in medical school curriculums in Oregon, and it's even filtered down to the community college level, where people who are pursuing allied health degrees will be learning about medical aid in dying and end-of-life conversations. So as Atule Gawande said, the medical profession has been surprisingly unprepared to deal with end of life. And in Oregon, they've made great strides.
Right. Right.
In fact, in Oregon, initially, hospice care for terminally ill patients was about 2 weeks long. And now, Oregon uses hospice much more appropriately. And the people who are using medical aid in dying are in it an average of 7 weeks rather than 2 weeks.
Right.
So the people we have to get to are the specialists who are not using palliative care as much as they should be, and not having these conversations. And that was something that was illuminated in the Aid in Dying in America from the Institute of Medicine.
So aid in dying seems to increase the conversations, increase hospice, increase
Absolutely.
palliative care, and it just brings that into as more and more people. So it's a very positive conversation. We're coming to the end of the program, and I wanted to ask you both, or one at a time, what you want viewers, somebody who's sitting in their home watching this, looking at their phone, looking at their television, what do you want them to take away? What's the biggest takeaway from this for you?
I thank you for the question.
Yeah.
We are trying to normalize the conversation around death and dying. We've already talked a little bit today about the fact that we have a death-denying culture. We can't even say the words dead or dying or death. We use euphemisms like passed on or kicked the bucket, bought the farm, or passed. I find it curious because living things die. Trees die, stars die, plants die, animals die, and humans die. When you're born, you're going to die. It's a package deal. It's part of living. So we are trying to normalize. We're trying to normalize the conversation here and make it easier for people. I always like to say, if you can hear my voice, that means that someday that you will die. I know that it's a bit harsh, but it's true nonetheless. Medical aid in dying is just the latest option added to a list of options that we've already had. Option is actually the word of the day. It is in the title of the bill. That's how important it is. So if you get a diagnosis, don't just get on the bus and go along for the ride. Get information. Find out what your options are. Know everything that's available to you. And then you can participate in the medical decisions that are being made. It's really important. I'd like to end by saying that...
I wanted to say a couple of things before we say goodbye.
Okay.
Okay? I just wanted to say it's really important to do your homework now. Remember that first discussion about 70% of people dying in hospitals? Do your homework now. Bring it to your doctor. When you bring the discussion to your doctor, it's upfront and personal, in their face, in their exam room. And it pushes the moral question for them to know, to think about what is their ethical position. And, you know, doctors are busy, they're distracted, you know, it's not something that they're going to jump on, but when a patient brings it right to them, then they have to consider what they think about medical aid in dying and whether they will participate. Yeah. We know that there are a few barriers other than the late request, which Alina spoke about. The one barrier is that it takes a minimum of 16 to 17 days if you're in a positive, full-fledged, everything on-track system. But it takes longer, up to 6 to 8 weeks, maybe longer if you have to change your physician because they're non-participating. So we know that the provider lack of information and that lack of decision-making can be an obstacle, and that it needs to be addressed really early. Even systems that are opt-in will say, oh yes, we're going to do this, this, and this, but by the way, you have to have a psychiatric consult, and
right,
that really slows down the
Yeah.
process, and it limits access. So the other things that I wanted to say is that in an opt-out situation, there's not a gag order. That employees from the janitor and the groundskeeper all the way to the chief of staff can by law discuss medical aid in dying with patients, and can by law refer that patient to a participating doctor or system. It's very important that the doctors and health providers and systems that are opt-out know that there's no gag order. Despite how the internal policy may be written, it is not allowed by law. That is illegal.
You mean they can all talk about it?
They can talk about it and they can refer.
And that's one of this, we were talking about the access campaign. So we have what you two are doing here, what us three are doing here, talking to individuals, but we also have Compassion on Choices has the physician-to-physician program, and bilingual. All of our programs are bilingual. So we have a physician-to-physician program where physicians can call in to talk to other physicians, to ask them about these kinds of questions. And then you mentioned earlier the pharmacist-to-pharmacist program, where again you can call into these programs and pharmacists can call in and get information.
So we are showing that information right now on the screen, and the numbers are there for the listening public to write down and feel free to access. The top California hotline number is a way to get directed to the service that you need. And there's also, as Virginia mentioned, the doc-to-doc hotline, and it's manned on the other end 24/7 by doctors in Oregon who have vast experience with medical aid in dying. And the pharmacists are there for other pharmacists and for other physicians who need to know what drug, what's the dose, how do I get it. So all that is available, and it's shown on the screen right now. There were just a few more comments that Alina and I wanted to make.
Sure. We have a few more minutes, a couple more minutes.
What we wanted to say is that there really are really only two things that matter in the end-of-life care, and that is respect for the patient's wishes and comfort for the patient's suffering, both physical and spiritual. And we like to quote Dr. David Grube, who's the National Director of Compassion and Choices, and he has said, death is not the enemy, suffering is the enemy. This law doesn't cause more people to die, it allows fewer people to suffer.
Good job. And what I'd like to say as a final comment is that I know that it's scary. I know facing your death is scary, but we're all in this together. We've all got to do it. So from my heart to all of your hearts, I wish you a safe journey and a peaceful death.
Thank you so much,
Thank you.
both of you, for volunteering, again, countless hours to this effort. And we have about 1,500 people in just the state of California alone doing this similar work. It's going to take, it's a movement that is moving forward nationally. Susan said earlier that the citizens of the state of Colorado just passed an aid in dying law that's based on the Oregon law, that's based on the California laws based on. These laws are very, very similar. They have some differences, but mostly they're the same. In Washington, D.C., the council just passed the law to go to the mayor, so that will probably be in Washington, D.C., there'll be a law there soon. And we're seeing it move through legislation in New Jersey. And in 20 other states, we expect it to be introduced next year into...
So exciting.
Yeah, so it's happening. It's something that's actually, it's a positive social movement that's actually happening. And it's a positive social movement that is really one little part of a larger movement. So aid in dying is an option. It's not like we're all thinking, oh, if
Not
we get aid in
mandatory.
dying. Yeah, it's not like we're fighting for aid in dying, we're fighting for choice.
Correct.
Because the idea is we want to open up choice, increase the conversation around dying and death, and decrease the suffering. And it's moving forward. So I want to thank you for your time watching the show today. And I want to also say, and to remind the audience, that Human Rights Here Now airs every Thursday from 9 to 10 p.m. on Comcast Channel 27 and Charter Channel 73. And each program is repeated a number of times. So thank you for watching.